everyone. Welcome to our COVID-19 virtual information session. My name is Pam Yankilov, and I'm the Director of Research at the Traeger Institute, and we're glad you're with us this morning. We do ask that you go on and type your county into the chat. This helps us get a sense of our degree of reach throughout the state of Kentucky. So I see people doing that. Thank you so much. We are going to begin our session today with Dr. Christian Furman. She's going to share an update on COVID in our state. Hi, Christian.
Hello, sorry, we just had to get the unmute going there. So yes, I'm Christian Furman. I'm a professor of geriatric medicine and palliative medicine here at U of L, and happy Thanksgiving week, everybody. So I just want to kind of give the updates from what the governor said on Wednesday when he did his press conference. And there's been a lot of changes throughout the state based on the COVID positivity rate and the community spread, which is real. And we're seeing a surge at U of L Hospital and all the all the hospitals, U of L, Baptist, Norton's. We're pulling residents off rotations and putting them on the hospital service and kind of going to where we're having doctors quarantine so we have a healthy workforce and nurses. We are having a problem in all of healthcare, the nursing homes, the hospitals, the clinics where, the providers are getting sick. And so then there's nobody to replace them. So, we're putting people on rotation so people are staying quarantined so they don't get sick. But the governor's big things is that, restaurants and bars, there's no indoor food or beverage consumption, carry out and delivery are encouraged. So please support your local businesses. Socially distanced outdoor seating is allowed. The schools, now all public and private K through 12 schools are cease in-person instruction. And then middle school and high school to remain remote or virtual until January 4th. Elementaries will be allowed to resume in-person instruction December 7th if they follow all healthy at school guidance and the county is not in the red zone. The red zone, is the highest infection rate. So private social gathering, so this includes Thanksgiving, right? Up to 8 people from a maximum of 2 households. So you don't want to have all these people mixing because then you just spread the virus. And I would encourage you at Thanksgiving time to, wear your mask when you're with your family, and, when you have to eat, sit 6 feet apart, everybody at their own table that's not been quarantining together. So you can still, get together, but get together safely with a small group and maximum of 2 households. Gyms, fitness centers, pools, and other indoor recreation facilities, 33% capacity, maintain at 6 feet apart, no group classes, team practices, or competitions. Masks must be worn while exercising. So I do play tennis, and we played my first match with a mask on, and it's very hard to do, but it's not impossible. And, it's good to still exercise and stay healthy, but you have to follow the guidelines. But those guidelines do not include college or professional athletics. And venues, event spaces, and theaters, each room will be limited to 25 people. So this applies to indoor weddings and funerals. And professional services, which, that's our office at the Traeger Institute and the Optimal Aging Clinic. Office-based business is limited to 33% of employees. All employees who are able to work from home must do so. And all businesses that can close to the public must do so. So our offices are open just like normal hours, and our labs open just like normal. But we have encouraged all of our patients to go to telehealth if they want to, and if they're able to still limit the exposure for our patients. And a lot of offices are doing that. And then we are going to a skeleton crew that are working. So we always have a provider, we always have a front receptionist, we have a medical assistant, but some of our support staff have gone home, and we've had people working from home the whole time. So things are changing because we are trying to keep everybody healthy. And these requirements are in effect now. They went into effect on Friday at 5 p.m. They last through midnight on Sunday, December 13th. So, please stay healthy and follow the guidelines and wash your hands and wear your mask. And really, U of L Health has gone to a policy where if you have your mask on and you have eye protection, glasses don't count, but glasses that have the side protectors or, face shields or goggles do count. So if you have your mask on and proper eye protection, you have a 0% risk of exposure. So if we do end up taking care of patients that we didn't realize were COVID positive, and then like the next day they come COVID positive, and it's like, oh my gosh, I took care of that patient. but you're not exposed because we're all wearing our mask and we're all wearing our eye protection. So I'd encourage you, if you are going to travel or fly or anything, wear your mask, wear your eye protection. There has been some research that people with glasses are getting less COVID. So Pam, yay.
Yeah, right.
These glasses come in handy.
That's
So,
right.
so wear your glasses when you go to these COVID events. And I'm sorry, these things. I'm sorry.
You mean Thanksgiving events?
I'm sorry. It's so crazy. So just follow the precautions, and it's just a very, very stressful time. I feel like we're back in March again, when it's so
Yeah.
stressful. So, but everybody just, yeah, Freudian slip. So everybody just, everybody follow the guidelines, and that way we don't have to like enforce these rules. We can just all do the right thing. So, all right, I'll be available for questions at the end too.
Sure. Thank you. Any recommendations for grocery shopping?
I know it's so busy, and like the shelves are empty of every pie and every sugar and toilet paper. Yeah, go, and it's the least amount of people there.
Right.
Whatever
Right.
that is, and
Yeah.
wear your mask and wear your eye protection.
That's right. I'm thinking at 10 o'clock tonight I might go. All right. Thank you so much. Thank you so much. All right. You're going to be around for questions at the end.
Yeah.
All right. Thank you. Now we have our session with Dr. Rochelle Holm. So we're excited to welcome our guest speaker, Dr. Rochelle Holm. Dr. Holm will lead a conversation exploring what we've learned through the monitoring of our sewer system in Louisville during the COVID-19 pandemic. As an integral part of the Co-Immunity Project, Dr. Holm will be able to give a unique perspective on identifying geographical and demographic factors that can contribute to outbreaks. So Dr. Rochelle Holm received her doctoral degree in environmental science from Washington State University. She works primarily on issues of waste, sanitation systems, hygiene, and rural water supply. Her nearly 20 years of global experience has focused on bridging the gap across boundaries of research and innovative practice by working together with communities, officials, academics, and analysts. So we are so happy that you're here to share with us. It's a very interesting topic. So you have the floor. And what we do is we try to be very conversational in nature. So you can do some beginning remarks, and then we'll jump in and see what kind of questions folks have. So as long as you want to go.
Thank you very much. Well, hi, my name is Rochelle Holm, and I'm a sanitation researcher with the University of Louisville Christine Lee Brown Environment Institute. And thank you for joining my presentation. Today, I hope to share with you about how the field of wastewater-based epidemiology is part of the data being used by public health officials for tracking COVID-19 in Jefferson County and around the world. A little background on myself is that for nearly 10 years, I've worked at a government university in the East African country of Malawi, where as an associate professor, I study community poop, where people defecate, why they choose to defecate in the open, how thick poop is in septic tanks or basic pit latrines, and how to pump it, but also using pooled community poop in these non-sewer sanitation systems as a look at community health. I'm currently part of the team at the Christine Lee Brown Environment Institute, working on the Co-Immunity Project, which Dr. Bhatnagar talked about last session. The Co-Immunity Project at U of L has three parts: the COVID-19 prevalence assessment of individuals via PCR testing, the prevalence assessment of individuals via antibody testing, and the last is wastewater monitoring and cross-validation via PCR, which is a part I will talk about more today, starting with the basics of using community stool for health indicators, an overview of wastewater-based epidemiology, and finally, our research approach and preliminary findings by U of L for Jefferson County. So let's talk basics when looking at community stool. Globally, the median stool weight is 126 grams per person per day for high-income populations, but almost doubles at 250 grams per person per day in low-income populations. The mass of stool is highly dependent on fiber intake. Thus, these differences in per person outputs based on what high or low-income individuals eat is important when looking at community stool. stool generation rate, where people defecate at home, school, or an office, and when people defecate is also a factor that must be considered in wastewater sampling. Global stool frequency ranges from about 0.74 to 1.97 defecations per 24-hour period, with the median value of 1.1 defecations per 24-hour period. This may indicate sampling sewers 1 day per week could exclude large portions of the sewer population, and especially those women of childbearing age who are less likely to have regular 24-hour defecation cycles. The majority of defecations occur in the morning from 6 to 10 a.m., with fewer defecations in the window of 1 to 5 a.m. The study of using pooled community stool as a community health indicator is not new. For example, it has been used in non-sewered sanitation systems, such as septic tanks and pit latrines, to give a historic look at pathogenic bacteria, viruses, and protozoa. And while in some of the low-income countries where this has been used widely are affected by things such as cholera, here in Jefferson County, this is not as much of an urgent concern for public health. And so now globally, we are trying to transition from historical, what does community stool say about health the last few years, to using pooled community stool samples that are flowing in an underground sewer line to give a glimpse simply by what has gone down the toilet the last few days. And people deposit much more than stool into toilets, such as trash and pharmaceuticals, dumping pills down the toilet. The application of wastewater-based epidemiology has been used to an extent in sewers for monitoring illicit drug use, polio, hepatitis E, and HIV for low-cost, real-time estimates and monitoring. And the U of L has ongoing research in developing testing methods for indicators of cardiovascular disease for our Green Heart project. So let's jump to stool being used for tracking COVID-19 here in Louisville. So Louisville, Kentucky is representative of many urban cities across America and has a population of about 770,000, covering 380 square miles. The 15% of the population classified as being in poverty are dominantly located in the northwestern portion of the city. There are 5 water quality treatment centers, also known as sewer treatment facilities, operated by Metro Sewer District that manage what goes into our sewer lines. The sewer lines contain active elements that have been in operation for over a century here in Louisville and combine rainwater runoff, industrial wastewater, and domestic sewage into the same pipes amongst most of the network, similar to most cities in the eastern United States. This combined wastewater system leads to large temporal fluctuations in the flow rate and composition of wastewater flowing through the sewer system. Most solids at treatment plants will turn over every 24 hours. So wastewater sampling allows moving from individual stool testing to a pooled community fecal indicator. Data from wastewater testing is not meant to replace existing COVID-19 clinical surveillance systems, but is meant to complement them. But also, clinical-based population screening is difficult and resource extensive, and getting repeated real-time population-specific COVID-19 clinical results is difficult. Currently, most SARS-CoV-2 or COVID-19 clinical monitoring is voluntary and inconsistently available, except for a few occupational and educational settings, and therefore likely still underrepresents actual population prevalence. And limiting detection to symptomatic individuals makes it difficult to reconstruct clusters of infection in neighborhoods of a city in a timely fashion. Also, individual clinical testing of those presenting with symptoms of COVID-19, while effective, it misses asymptomatic individuals who are actively shedding the virus. SARS-CoV-2 can be shed in the feces of individuals with symptomatic or asymptomatic infection. Therefore, wastewater sampling can capture data on both types of infection. There is evidence that the virus shedding in feces occurs up to 7 days before clinical symptoms and testing, and also in those who remain asymptomatic. Other research has indicated sewers as a day or two advance notice ahead of COVID-19 confirmed clinical cases. A study from Hong Kong reported that 48% of patients had virus RNA for SARS-CoV-2 detected in their stool even after respiratory or nasal samples tested negative. Tracking the sewers has also gotten media attention recently, with some universities saying they have caught dorms COVID-19 outbreaks by tracking the fecal material coming out of those dorms. But whereas a close relationship between stool and wastewater samples has been reported for polio, this is less well established for SARS-CoV-2, where interpretation of the signal beyond presence absence or copies of SARS-CoV-2 RNA continues to challenge broad application of wastewater-based epidemiology for SARS-CoV-2. Moving from treatment facilities to neighborhood sewer lines introduces factors that preclude comparisons across sites. For example, sewer systems are not always mapped accurately, and sewer lines, in addition to household waste, may contain combined commercial, industrial, and often rainwater, which complicates the consistent and comparable sampling of stool due to inconsistent dilution of household waste. Furthermore, these sewer lines often have complex technical and geographic characteristics from ad hoc expansion due to growing populations. Therefore, a key barrier for developing epidemiologically comparable and geographically resolved monitoring of SARS-CoV-2 in wastewater is the lack of established methods of sample site selection, specifically designed for community-wide disease surveillance to isolate pooled community stool from the other sewer inputs. There are two primary field methods being used for wastewater monitoring of SARS-CoV-2. The first is grab samples, which are a discrete sample at a specific day and time, usually by dipping a container on a rope into the sewers. The problem with this is that it is highly dependent on who defecated in the area and flushed in a narrow window of time prior to sewer sample collection. And defecation frequency is highly individual, as we discussed earlier, and not always on a daily basis. As such, this grab sample is the least representative of a population. The second is composite samples. Composite samples use a portable automatic sampler with tubing reaching down into the sewers to collect a small volume of sewer water every 15 minutes over a 24-hour period to fill a 4-liter jar. This is then mixed together in a larger jar and an aliquot is sampled from. This sample is more representative of area level population and what we are using at U of L. Beyond how to collect a sample is the scale of our sample sites. Wastewater monitoring of SARS-CoV-2 as environmental surveillance to complement community clinical surveillance for infections can be done at 3 scales. The first is at a facility or building level. The second at sections or neighborhoods within communities at sewer line manholes or pump stations. And third, for an entire community at established centralized wastewater treatment facilities, where Jefferson County has 5 treatment facilities. The treatment facilities are well set up for compliance sampling and allow a highly representative community level sample. However, treatment plant samples don't allow fine-tuning to determine where in a community higher infections might be, as all the fecal material is mixed together. Around the United States, most monitoring of SARS-CoV-2 in wastewater has been at treatment facilities. Current guidelines for wastewater sampling are well established for influent or effluent at treatment facilities by EPA for compliance, civil and criminal investigations, and water quality studies. However, these treatment facility sampling guidelines typically are not well suited to epidemiological modeling of community-level fecal monitoring, and especially when new and rapid development of analysis methods is occurring in parallel, like for COVID-19. For this co-immunity project, we used a geographically resolved population-level wastewater sample site selection protocol for Jefferson County, based on 3 sets of data. The existing sewer data in Geographic Information System format, GIS, for the MSD, which allowed rapid design and deployment of this research. These data included information on the location and attributes of all sewer lines and access points within the city. We also looked at citywide socioeconomic data, such as income levels, and lastly, other clinical health geography data. Because data from wastewater monitoring for COVID-19 has the potential to identify groups of individuals, it is sensitive human health related information that requires attention to ethics to not make our sample sites too small, and importantly, with no personally identifiable information included. Some of our inclusion criteria for wastewater sample sites were: we focused on residential coverage with water toilets serviced by municipal sanitary sewer systems. We looked at locations overlapping recruitment areas for randomized resident testing of the corresponding co-immunity individual prevalence study. To ensure samples were anonymous, we used a minimum neighborhood population of 5,000. The recommendation for wastewater poliovirus monitoring is a sample population of 100,000 to 300,000 people. However, our project required sample sensitivity to be directly comparable with our concurrent co-immunity nasal diagnostic clinical study, justifying a smaller sample population at neighborhood resolution related to zip code populations with raw wastewater. We looked at the accessibility to sewer lines with free-flowing wastewater, such as street lines, pump stations, and main treatment facilities. We looked at contextual information, flow rate, and temperature. We looked at feasibility with field human resources. And lastly, for manhole locations, we needed free-flowing wastewater that was not more than 25 feet below the street level due to some of the sampler equipment limitations. Then we went through and we had 4 exclusion criteria, which were: we did not want samples downstream of majority commercial or industrial sewer outflow or hospital sites, even if surrounded by residential households. We excluded water toilets not connected to municipal sanitary sewer system, such as areas where septic tanks were in use. We excluded any sites not practical for field sampling, such as the area around a manhole not offering enough space or safety for field personnel or traffic safety issues. And we also excluded areas of high temperature wastewater. We then went back in and had deliberate additions. We added back in each of the 5 treatment facilities in Jefferson County, and we added higher sampling in the northwestern portion of the city to ensure inclusion of residents with a disproportionate health risk. We are purposefully over-selecting geographic areas in the county where clinical COVID-19 testing is not guaranteed. We contracted with MSD for access and sample extraction at sample sites. Sampling personnel from MSD set up a portable automatic composite auto sampler for us. After our initial site selection, we performed an initial round of sampling. We excluded one site due to higher than expected industrial outflow visually. This sample was at an elevated temperature due to a nearby distillery. Elevated temperatures have been reported to make wastewater samples vulnerable to over or underestimation due to possible degradation of SARS-CoV-2 over time. So I use this example to show how much qualitative reflection went into our Jefferson County sample site selection. Based on the design of sewer lines in Jefferson County, there was a steep decline in information value of additional sites beyond 17 locations. Ultimately, our sewer neighborhoods have a variation in income from 24,000 to over 100,000 and a population minimum of 7,000 residents. We started collecting sewer samples in May in partnership with MSD. Initially, we sampled once per week, but as community transmission has risen, we have transitioned to sample twice a week. We currently are looking at 12 sewer neighborhoods at sewer line manholes or pump stations, which cover most of Jefferson County and each of the 5 treatment facilities operated by MSD for a total of 17 sites. Importantly, our wastewater testing is done passively at a lower cost for less than $400 for analysis and with fewer human resources, making it a more feasible approach for full citywide coverage alongside widespread clinical individual testing. Well, what do our nearly 700 samples of pooled community poop show from Jefferson County sewers? Well, actually quite a lot to add to the COVID-19 story of our community. Early findings are that every site shows the prevalence of SARS-CoV-2 in the sewers, regardless of income or residence dominant race. Most recently, we have seen increasing trends in our wastewater results. While many other cities are doing SARS-CoV-2 wastewater testing, the innovation in this study is our neighborhood level geographic site selection approach in partnership with MSD. We are able to plot the recently increasing trends of SARS-CoV-2 in wastewater, not only at a citywide level, but at a neighborhood level. Population demographics do not change much since we consistently, over time, collect samples from the same areas of known demographic characteristics. One wastewater sample is not useful, but a trend over time can really assist public health monitoring and customization at a neighborhood level within our community. The results indicate great variability between sample sites, even with populations of 10,000 and 25,000. Our results see variability in SARS-CoV-2, but also that if we were only sampling and looking at those 5 county treatment facilities, we may not have a full picture of our community. This may help provide more context for vigilance in areas where the infection may be more prevalent in Jefferson County. Looking also at the human capacity on how to get this COVID-19 community data from pooled stool samples. Sewer districts are designed as essential service providers to move waste safely for protection of human health and the environment. Wastewater samples human capacity moves to using essential workers at the sewer district in its place of healthcare workers for collecting COVID-19 community data. There are 3 primary sources of variance in our ongoing work at epidemiological modeling using wastewater. First, the shedding of individuals of SARS-CoV-2, which is still currently being studied widely by clinical researchers. Second, the uncertainty depending on sample size and strategy, subsampling, where there are a lot of real-world logistics that go into how to get sewer system samples, and where many parts of the Commonwealth have residents without central sewage services. And lastly, laboratory analysis, where the SARS-CoV-2 wastewater methods are still currently being refined and have wide variation between academic or commercial lab methods throughout the United States. Currently, wastewater-based epidemiology is being used as a frontline technology across the globe, but this lack of lab analysis standard methodology is something the CDC and EPA are actively working to harmonize efforts nationally. Originally, we did not have the capacity at U of L to perform wastewater analysis for COVID-19. From May until August, we shipped our samples overnight to Arizona. But with an amazing lab team at U of L that worked tirelessly, and I mean many, many late nights, learning from other work nationally and globally, while adding in their own innovation, we can now, with cardinal pride, expertly offer wastewater analysis for COVID-19. Currently, we have spun out some of this innovation in laboratory analysis to a private commercial lab here in Louisville under a U of L research partnership, as a leading example of the role of the private sector in supporting public health efforts of the pandemic. Although the Co-Immunity Project is based here in Jefferson County, more widely, the Wastewater Project team is also working closely with Sanitation District 1 in Northern Kentucky for wastewater testing and the Kentucky Waterways Alliance for testing surface water in Jefferson County for SARS-CoV-2. One of the most important uses of this data is how to use and share our results quickly. We have weekly meetings with Louisville Metro public health officials, which allows integrating our wastewater data alongside other data, where wastewater testing at scales of hundreds of thousands and down to thousands of individuals allows customized resident interventions for public health risk communication approaches and for targeted strategies to decrease infection rates in our community. With that, thank you for your attention, talking about poop before lunch, and more importantly, the pooled poop of our neighborhoods here in Louisville. As awkward as it sounds and jokes aside, it is also an important part of the U of L research to provide useful public health surveillance to inform geographically targeted strategies to reduce SARS-CoV-2. I would like to thank our essential partner with MSD for their collaboration and daily support, which allows U of L to do this innovative research in our community. I would like to open the remaining time to a conversation with you on this topic of using geographically resolved wastewater samples to estimate community prevalence of COVID-19. Thank you.
Thank you so much, Dr. Holm. That's great. All right, now it's time for questions. Does anyone have any questions? So let's see, we have a few questions. All right. I'm trying to find them. So here we have one from Colby. Given that the virus can shed in fecal matter 7 days before onset of symptoms, and in cases where the nasal swab test is negative, should we be treating the epidemic in the same way we would a hepatitis A outbreak, especially with regard to restaurants and produce? Are you still, you muted? You can't get, Justin, can you assist? Let's see, is that any better now?
We're good, thank you. That's an excellent question. And I think one of the problems that we're all addressing currently is how to do wastewater-based epidemiology for SARS-CoV-2 when there's so much remaining unknown. So for monitoring illicit drugs or polio, it's very well established, also HIV. So how to apply our model when we have wastewater results to infections in the community, that link is not well established currently. So we know the copies per milliliter SARS-CoV-2 RNA in our wastewater, but how that translates to cases out in the community, that link is less well established than for other wastewater-based epidemiology approaches.
Okay, thank you. Let's see. Colby, are you suggesting that COVID-19 might be transmitted or contracted from contaminated food, similar to hepatitis?
I have not seen any research specifically addressing that. It's widely known it's a respiratory disease, and so that fecal oral transmission has not been studied, but I think researchers are still working on that. So it's a good question, and we should watch literature as it comes out, hopefully in the next year, to address that question.
All right, Andrea says, good morning. Dr. Holm, do you foresee stool sample testing being utilized at all for people who need early and accurate testing?
Yes, I do. I think that's a great opportunity. And especially if you're, for example, going into a care facility, it would be one way to monitor before a nasal test would be done. But also thinking about the limitations of where people poop, right? They poop at home, not as much at school or in an office. So making sure that the context on where you get that sample is appropriate. And also knowing that wastewater samples do exclude portions of the population, specifically children that are in diapers, where their fecal waste is not going into the sewer lines, or if there's an older adult that also does not use the toilet, but they have other systems, that would also be an area where wastewater-based epidemiology for SARS-CoV-2 is excluding portions of the population. So I do think that individual testing, there is a role for early, that's a very good question, and I don't believe it's been done yet. So we should add that to our research list.
That's interesting. Let's see. So you sent a copy. You sent a Teams pre-copy on the Jefferson County research covered in the presentation today. Thank you so much. So we can go on and look at the research protocol that was used. Tom Walton has a question. Is there any coordination with providers in neighborhoods to alert them to high incidents identified by your study?
Tom, that's a great question. And so this is not just research for global publication. This is really research that impacts the community where our U of L wastewater team lives. And by meeting with Metro public health officials every week, we are able to get our U of L research data to the hands of the people who make those decisions about working with neighborhoods. So U of L does not reach out to the neighborhoods, but that is the role of public health. And we're excited to have that weekly standing meeting with them.
So can you tell us a little bit about when the information from the wastewater was communicated to the team, what did they do? Like, did they ramp up testing? Did they move testing centers to neighborhoods? Did they, and was there any time when the wastewater information was different than what they were getting from, like, maybe their testing, and what happened there?
So there's always a lag time in testing, whether it's nasal or wastewater. And so wastewater results, we typically get them within 36 hours. So roughly about the same time as we're seeing clinical results. I am not part of the team that meets with Metro, and so I understand that's a very good question. Maybe there's somebody else on the call today that would be able to answer that, but I'm not as much on the risk communication side. My research focus on the wastewater sample collection and data side.
Mm-hmm. Okay, all right. Can I ask you something that you said at the beginning of where you were talking about the number of grams per person, and you were talking about the number of grams per person versus high income versus low income? And I thought I heard you say that there was 126 grams per person per day for high income and 250 grams per day for individuals in low income, which is interesting to me, because I would think that it would be the reverse, because in high income, you would think that there'd be more access to fruits and vegetables, which would mean more fiber, which would mean more, but that's not the way it goes.
There's very limited research in how much individuals defecate and the frequency of their defecation. So some of this SARS-CoV-2 wastewater-based epidemiology is looking back at papers from many years ago. And so, yes, that is what the systematic literature review that I cited indicates, is that low-income individuals have almost twice the mass of stool per person per day.
Interesting. Okay. I thought I heard it wrong, but no. Okay. Are there other questions in the chat? Let's see. Not as of yet. You guys keep your questions coming. So let me ask about the sewage workers, and this might actually get at what Colby and Justin were. So is there any additional precautions for the individuals that are taking the samples and acting on the samples? Is there anything there?
So we have a great team at MSD, and they're always very cautious in all of their activities, and especially now during COVID-19. So I have demonstration. So thanks for asking. To pump our samples out of the sewer, we have small tubing that goes all the way down into the sewer lines, and it comes up to automatic composite samplers that MSD operates for us. And then pumping from that container into our sample bottle, we would use a handheld pump like this to reduce the aerosols. Then we pump into our small bottles. And so this is one example of a very easy fix to reduce any potential for aerosols, in addition to all of the other PPE that MSD is using on a daily basis. But thinking outside the box, how do we make this simple and clean and reduce aerosols? So these are just, we do 2 bottles for every site, and it only takes a few minutes of time. So all of the MSD personnel, they would all be in eye protection and masks and Tyvek suits as well. So we're very grateful for all the safety precautions that MSD takes on a daily basis to get these samples.
Very interesting. And I may have missed this, but who is your funding source for this great study? Is it, I'm sure I missed that, but.
I think I would have to get back to you on that.
Oh, that's okay.
I'm not.
I was just wondering, is it Whole Foods?
The sewers, come on. I'm very, very sorry. Inappropriate response, but I don't know. Maybe there's, I can follow up with you on that.
That's okay. Yeah, I was just wondering. Let's see. I think there are, okay. So, you posted the Co-Immunity Project site. Thank you so much. Mary said, since nursing homes are seeing such elevated numbers of cases, can you see those results from testing near those locations?
Yes, you can. And there is some facility testing. This team as well at U of L is doing facility testing. We were out today collecting metro housing samples. So that is being used on a limited basis to track what's coming out. Prisons is another example of facilities being tracked. Now, you think about long-term care facilities and prisons, people are going to defecate. Whereas it's going to be less useful, for example, at a school that is just operating a few hours per day, because children are less likely to defecate. And you really need that stool sample to have your SARS-CoV-2 indicator. And so you really have to think, it's not just going to get a sewer sample, it's really thinking about where do people defecate and moving from individual stool to pooled community stool samples. So yes, long-term care facilities is a great potential for that.
Very interesting. Let's see, we have another question from Tom. What causes the difference in stool volume in high and low neighborhoods? Yeah, the high and low income neighborhoods, we just talked about it. Yeah.
It's fiber intake. And actually, Justin, could you unmute one of our wastewater team members, Dr. Ray Yeager? He will actually be able to come in on the funding question. And I'm sorry, I don't know that answer from two questions ago. So Justin, could you unmute Dr. Yeager?
Hello, can you all hear me?
Yes.
Great job, Rochelle. Yeah, just jumping on a couple of those questions. Funding, I think, as Lauren pointed out in the comments, we received basically a gift for COVID response from the Owsley Brown Second Family Foundation. That kind of got us off the ground with wastewater sampling. And then a lot of it is also funded, and this was later on with CARES Act funding that goes to Louisville Metro. So then Metro allocates some of that CARES Act funding to us. And then I think there's a couple other smaller sources, but those are the main ones. And then in regards to the public health communication side of things, yeah, we have those weekly meetings with Louisville Metro, and we go through each of the sewer sheds one by one and talk about what the detections are, what the rates are. We compare the Metro testing rates with the sewer shed marker detection levels. So we kind of analyze the trends. So we're a little bit more concerned about the trends than the actual numbers.
Yes.
And that sort of gives us another data point on where cases are rising, where they're falling. A lot of the summer was kind of spent figuring out what the public health implications of this actually are and how reliable the data are and refining some of the methods. But we've definitely had conversations about targeting testing and targeting enforcement of existing suggestions and mandates and all that good stuff. And it's really just kind of one data point with all of the other information that Metro has to really go do the interventional work and the contact tracing and all of that they're doing.
Mm-hmm. Was there ever a time when the wastewater was, came sooner than the testing information and they realized they needed to act on it quickly? Or
there was, and we didn't really jump at it because we occasionally have a sample that sort of jumps around and in lab output values that could be for a number of reasons. So we take it with a grain of salt, but if it looks like both indicators are trending in one direction and we see wastewater jump, then we certainly pay more attention to it.
What was there a reason for not doing wastewater close to dorms or universities or anything like that?
Rochelle, I think you were more involved in that particular question.
There was some talk about doing the dorms here at University of Louisville. This goes back to the logistics of getting sewer samples. There was not sample manholes that were easy to sample for those dorms. Sewer lines are highly complex. And so when you're doing analysis for SARS-CoV-2, you want to maximize the individual stool sample while minimizing any industrial or hospital waste. And so sewer lines are meant to move waste for protection of human health and the environment. And they do a great job at that, but they're not necessarily well set up for epidemiological modeling and monitoring.
Oh, interesting. Okay, I think we've got a variety of other questions. Okay, so Andrea says a little off topic, but are there any recommendations regarding wiping down groceries, mail, packages, retail purchases in the rare event that fecal matter with SARS-CoV-2 is present on those objects?
While I'm not aware of any research related to that, I think this goes back to some of my work that I do across the globe. Keeping your hands clean. Wash your hands with soap and water after using the toilet. Not only is it something we should remind little children, but even adults in this COVID-19 time, that's the best way to prevent those transmissions. So I hear your question. I don't know the answer, but I would encourage you to keep up hand washing as another basic approach to reducing transmission in the community.
Thank you. Lauren says to support this work and other aspects of the co-immunity project, a groundbreaking collaboration to track and curb COVID-19, U of L has received a $1 million gift from the Owsley Brown to Families Foundation. You're excited to be featured in the New York Times Magazine today. Oh, that's exciting. So we'll all have to check that out. We'll have to check out the article in the New York Times Magazine. That's great. Thank you for including that, Lauren. All right, Karen says, I believe that UK is doing a similar study with special focus on dorms. Okay. All right, so maybe their manholes are set up a little bit different. All right, and then Mary said, I was living in dorms when the sewers blew during the hexachloride from Purina. So yep, that's definitely bad coming from your tests. Yes, thank you for that. All right, any additional questions that we have? So are you going to continue? How much longer is your project going to continue?
We were out sampling today, so that's a very good question. I think samples are coming in the next hour. So we are very closely watching our results before the Thanksgiving holiday and after the Thanksgiving holiday.
Right.
So we are continuing for several more months. I think the end date is to be determined at this point, you know, as the pandemic extends. And I want to remind everybody, wastewater sampling should not be used in lieu of clinical testing. It should be used alongside it as part of the story for what the community has as a big picture for COVID-19. And I think it's just a good reminder to everybody, this is a portion of the data. The more data, the more triangulation, the better.
So the sites that you provided early on, or one of your team members, does it show the trends of the 17 different sites?
The publication preprint that I shared is one that working on with Dr. Yeager. It will show you each of the 17 locations that we are sampling here with MSD in partnership. And we are currently very hard working on publishing some of our preliminary results, especially about the fecal indicators. So it's in progress.
Yeah, that's great. So the uniqueness about your study was the neighborhood sites perspective, getting so close to the, okay. Yeah, I heard that. Okay. All right. Let's see if there's anything else in the chat. Any other additional comments for Rochelle or Ray? Okay. Any additional questions for Christian? Anything else? Okay. Let's see. Yes, so great topic, very interesting topic. Yeah, that's off the beaten path. Yeah, you know, stool isn't something we typically think about, right? But what an amazing work that you guys are doing, and to inform us as to look at community stool at a neighborhood level to be one of the factors in the equation to educate our public health officials on you know, how to react and respond to things. So yeah, so a lot of praise is coming in, and thanking you for coming today and sharing your knowledge. All right, so I think we are going to call it today. Is there anything else, Christian, you want to add, or Ray, you want to add?
I learned a lot, Dr. Holm. Thank you so much. Yeah, no, just everybody be safe and have a good Thanksgiving.
All right. So what we'll do is there, let's see, I don't think I have the additional information about who's coming next. I don't know if Claire, I wonder if Claire knows who's coming next in our next session. I don't know. Justin, can you unmute
It's
Claire?
December 8th, I think, right?
So
it'll be a whole new month, December.
That's right. How did we get here, right? It all just a blur. All right. So were you able to unmute Claire, Justin? You are. Claire, can you jump on and share what our next session might be? Do you know?
Yes, so it's not confirmed yet, but the topic is we're wanting it to be on COVID-19 and transportation. So we're working to try to get the new director of TARC to join us for a topic on that. So stay tuned, stay posted. If you want to join the email list, we always send out updates when we have them on our COVID-19 sessions and everything else. So hopefully we'll see you guys back there on December 8th at 10 a.m. for that one.
Great. Thank you so much, Claire. And as you guys know, we will be posting Dr. Holm's presentation in this particular entire session on our website at tragerinstitute.org, and it'll be on the archived. And so hopefully too, we'll see if, make sure you guys go on and pull some of those. We'll make sure to pull some of those sites that you indicated and put that in there as well, so people can check those out. And we all should check out that New York Times article. Congratulations on that. All righty. Thank you so much. Thank you so much for your time, and everybody have a safe Thanksgiving. Thank you for joining us. Bye-bye.